So we are now recording. So I'm going to cover chapter 23. We're going to start with, if you're trying to follow along in your textbook, it's going to start on page 346. I am going to be on the PowerPoint slide, so I'm not going to be able to tell you all the page numbers the way that I could in the classroom. But we're going to get through this. So chapter 23 covers the body and drugs. And I don't know why I did that because I'm still going to read the introduction real quick. So our introduction for chapter 23 on page 346 says that pharmacists expect competent pharmacy technicians to know more than how to count, pour, and prepare medications. Although the pharmacist is responsible for providing pharmaceutical care to patients using his or her specialized knowledge, technicians too must understand the basics of pharmacology. So pharmacology can be defined as the study of drugs, including their composition, uses, application, and effects. This chapter introduces some basic concepts of pharmacology, including pharmacodynamics and pharmacokinetics. You will learn how the body absorbs, distributes, transforms, and eliminates medications. You will also review the effects of drugs and chemical abuse. So that's what we're getting into with chapter 3 today, or chapter 23. Today we're going to cover the pharmacodynamic concepts. So pharmacodynamics can be defined as the study of the biochemical and physiologic effects of drugs and their mechanisms of action of drugs. So most drugs are going to affect drug cells by interacting with specific receptors, and it works a lot like a key into a lock. A receptor is a molecular structure located on the surface of the cell that binds with a particular chemical or chemicals, stimulating that receptor to either produce or inhibit a specific action. So as we'll look at some pictures here in just a second, there's your receptor, and these are your various molecules. I'm not sure if y'all can see my cursor floating around, but the triangles, the oval, the square are your different molecules. So as you can imagine, those triangles are going to fit perfectly into the receptor site there on that receptor, which would thus block this oval or the square. The square could fit in there, but it's not going to fit as well. So it's going to have a limited action. But once it's blocked, it completely blocks it. Or if that triangle is representing an action that you want completed, of course, it's going to fit like a puzzle piece, again, like that lock and key. So we would see the full action of that product. So the receptor complex. A receptor on a cell is going to interact with a specific drug if the drug fits the specific structure of the receptor. And that's what we were just looking at in that figure. So the triangles would be the ones that would have fit into that particular structure receptor. Drugs are going to be designed to have the same or similar structure to the cell that it is intended to affect. So for example, antihistamines are going to bind with histamine receptors on cells, effectively turning them off and thus stopping an allergic reaction. Some of these drugs have shapes or structures that match more than one type of cell, such as diphenhydramine, which interacts with histamine receptors and certain nervous system receptors. This is why we get that main side effect that you hear with Benadryl a lot, which is drowsiness. And I know personally that affects me greatly. Site of action is the site where the action is actually occurring. So scientists are usually seeking a specific receptor for the drug to interact with. This is what we call the site of action. Even if the site of action is unknown, the FDA still requires that the manufacturers prove that the drug is safe and effective. Next, we're going to look at mechanism of action. This is looking at how a drug works and produces its desirable and sometimes undesirable effects. So an example here would be anesthesia, which is used for surgery. It interrupts the pathway between the central nervous system and the peripheral nervous system, so patients can't actually sense any pain. Here, figure 23.2 shows you the hypothalamus, where it is located within the brain. And the thalamus is pointed out there for you also. So why is it showing us the hypothalamus and the thalamus? Well, because these are key areas, sorry, when we talk about receptor sites and things. So when we're talking about a receptor site, we're talking about the location where that drug or chemical is going to bind to that cell, and that allows a specific molecular change to occur. So the known receptors are too numerous to list, and as pharmacy technicians, it gets outside of our scope of what we are required to know, or even what is necessary for us to know. And you just need to know that they are finding new receptors all the time. So this is an ever-growing, your doctors and pharmacists, that's part of their continuing education, is staying on top of those new receptor sites. Next, we're going to talk about agonist and antagonist drug actions. So they're giving you an illustration here, figure 23.3. The little orange squares are representing a chemical, where the rectangular green structure is your agonist drug. An agonist drug is going to prompt an action, and your antagonist drug looks like the half square with maybe like a little upside down hat kind of thing going on. The antagonist drugs block actions. So you see along the bottom of that figure there, normal chemical activity, the chemical is going to bind to the receptor site. That's if we have no drug in the system. The agonist drug will bind to a receptor site. This is the middle bottom circle or half circle. So that agonist drug will actually bind to that receptor site, and it'll cause the same action as the natural chemical would. So we're kind of aiding nature, because sometimes our bodies start ignoring what should naturally occur, or other things may be going on to cause the body to not be functioning properly in that way. So we'll use some drugs to mimic that. And then the semicircle on the bottom right corner is showing you the antagonist drug, how it fits into that receptor site. But because it's like that upside down hat, it literally will block anything else from attaching to that receptor site. Thus, it prevents natural chemical from binding to that site, or if there's another competitive drug, it'll prevent that other drug's action. So as I mentioned, as I was trying to describe that previous illustration there, the agonist drug is a drug that is going to produce a certain predicted action when it binds to the correct receptor. Whereas our antagonist drug will block that receptor and prevent other chemicals from actually attaching to it. So there are two terms you need to be familiar with when we talk about antagonist drugs, and that is affinity and efficacy. Affinity refers to the ability to bind to the cell receptor structure, and efficacy refers to the ability to impose on the cell and cellular structure and how to change how the cell behaves. So when we talk about agonists and antagonists, another term you need to know is target cell. When we talk about a target cell, we're not literally talking, even though it's singular in nature, we are not talking about a single cell. We're actually talking about a large number of similar cells that a particular drug is intended to act upon. Some of these target cells can be things like nerve cells and cells that are involved maybe within the heart or vascular system. So especially with respect to circulation, blood pressure, if we're talking about maybe an antidepressant, then we're trying to work on a group of cells within the brain rather than the heart, so on and so forth. So part of pharmacodynamics is understanding the dose response curve. And this is a curve that can be mapped out onto a graph to help determine the patient's response, because that's going to be directly related to the amount of drug that is administered, hence dose response. So dose being the specific amount of drug that was required to achieve the desired effect, and response to that drug, or the effect of the dose itself. And figure 23.4 gives you an illustration of a dose response curve where they're showing you along the left the intensity of the drug's response or percent of maximum response, and along the bottom they're logging which dose so that they can track and see where that peak response actually occurs. So with regards to the dose response curve, we have a ceiling. That's the point at which the maximum response is attained, and the same drug will have no further benefit, meaning if we continue to increase that dose, it's not going to do anything. This is the max we're going to get out of this drug. So harmful effects of the drug can continue, however, especially if we continue to try to add to the dose. And then potency is the measurement of the strength of drug required to produce a specific effect on the body. So that's how they determine, hey, we don't want you having more than this much drug within this many hours, so on and so forth. That's due to that dose response curve. There's no clinical benefit to continue increasing the dose. Another thing you need to be familiar with when it comes to the dose response curve is what we call ED50. This is a specific amount of the drug that will achieve 50% of the maximal response. This is an important concept because they use it to measure the full potency of a drug without having to actually achieve that level. So they find out what the halfway point is, and that is the ED50. Also, half-life comes into play. So when half-life is expressed in written form, it's with a capital T in the 1/2, sort of subnoted there a little bit towards the bottom. Half-life is going to refer to the time that is required for plasma serum concentration levels of an absorbed and distributed drug to decrease by 1/2. So we use that dose response curve to determine where our maximum response was. But we also have to watch how long it takes this drug to leave the system so that we're not overdosing or creating additional adverse drug events. So we need to know how long it's taking the plasma serum concentration levels to return to normal. And just like with the ED50, this is sort of in the opposite direction. Half-life is referring to how long it's half of the time to get this drug out of the system. So half-life is applicable to drugs that pass through the liver as well as the GI tract. And it's going to determine how many times per day a drug is dosed. If it has a longer half-life, that means there's going to be fewer doses per day. Likewise, if it has a shorter half-life, then we're going to need to take more doses per day. And figure 23.5 is giving you a visual illustration of what we call the time response curve. The other we were looking at the dose specific to the effect. With the time response, we're going to be looking at onset versus termination and how long that takes to occur. So time response curve means to determine the length of time for which a specific drug will continue to have the same degree of effect. If no other drugs or foods have an adverse effect on a drug, the time response curve will be a bell curve, showing the specific onset of action, which can be measured. It'll show the entire duration of the action, and it'll show what time the action is terminated. So another thing we have to watch for when it comes to pharmacodynamics is drug-drug interactions. First, you need to know that a drug-drug interaction is an interaction between two or more drugs that are administered to a patient, resulting in either an increase or a decrease in the therapeutic effects of one or more of the drugs, or an adverse event. There are certain things that just are not supposed to go together, just because they can affect one another. So we need to be aware of those things. Your pharmacist needs to be alerted when you see these types of alerts come up. As a pharmacy technician, when you're typing prescriptions, sometimes you will get drug-drug interaction warnings. Your pharmacist needs to be alerted to those. They don't always necessarily mean that the patient cannot have the medication. A lot of times they can. A lot of people have been on medications for years that can possibly have a drug-drug interaction. That just means that the pharmacist needs to talk to them about what to be watching for. Sometimes they just need to put a space of time between the two medicines that can interact. And there's some various other factors. But again, that's why your pharmacist needs to be alerted to that so that they can alert the patient as well. So when a drug-drug interaction occurs, or it can occur when an antagonistic drug is added to one that is not. So they're both trying to do opposite things. Or if an antagonistic drug is added to a number of other antagonistic drugs, they can be competing to block and thus cause an adverse event or effect. So when we're looking at those drug-drug interactions, we need to be mindful of the time that is needed for a drug to take its effect. That's going to be very important. Some of these drugs are processed through the liver, and some drugs actually build up metabolites, which are any substance produced by the metabolic process that do not have an immediate effect on the body. So interactions can take place much later when the drug is administered. So again, your pharmacist has much more training on this. The key thing for us with this is to keep an eye on it or alert your pharmacist whenever they need to, when these things pop up as a warning for us so that the pharmacist can make sure to dot their I's and cross their T's and address these things with the patient. Sometimes they might even need to address it with the doctor. It just depends on the interaction. And then lastly, that I'm going to cover today is drug testing. This is usually performed on healthy people, and this is not talking about the type of drug testing, to see if there's an illicit substance within the body. This is to determine significant differences in the effects of drugs in a real patient. So it's a different type of drug testing that we would typically hear about. Does anybody have any questions on the pharmacodynamics portion of the lecture? Alrighty. So that is where I'm going to stop the lecture today. Just like with our last chapter, there are a couple of pop quizzes within this chapter. And so I won't tell you when, but I will tell you that if I were you, I would be studying the terms and definitions associated with the pharmacodynamics portion of this chapter. Your first pop quiz will occur on that topic. Sorry. And then I had a request to go over how to pronounce your top 200 drugs for this week. Some of you like to say them out loud for study purposes, so I'm going to run through that real quick before I address any other questions. So hopefully my screen is still sharing and you see your drug list there before me. I'm not sure if y'all can see my cursor or not, but I'm going to start at the top and I'm going to read straight across from left to right, and we'll just work our way down the page there. So the first drug we have here, the brand name is Adipex. The generic name is phentermine. Some people enunciate it phentermine. I don't see an A in between the R and the M, so I call it phentermine. And the drug class is anti-obesity drug. Back to the left, next item down, brand name is Aricept, and that generic is donepezil, which is a cholinesterase inhibitor. Back to the left, our next drug down is Buspar. The generic name is buspirone, and that drug class is antioxylytics, non-benzodiazepines. Next item down, we have Depakote. Generic name is divalproic sodium. That belongs to the anticonvulsants. Our next item down is Keppra. The generic name of this one, I'm not going to lie, I'm not 100% if I say it right, but I call it levetiracetam, and that is also an anticonvulsant. Our next item down is Lamictal. Goes by the generic name of lamotrigine or lamotrigine, and that is an anticonvulsant, anti-manic. So you will sometimes see that for mood control. maybe if somebody is bipolar or something of that nature, but it is primarily an anticonvulsant, so you could see it for a seizure disorder as well. Lyrica is next, and the generic for that is pregabalin, which is primarily an anticonvulsant. However, I will tell you that you see Lyrica used off-label for nerve pain a lot, things like fibromyalgia and neuropathies. Next item down is Namenda, and the generic to that is memantine. That is for Alzheimer's, which is a type of dementia. Next item down, we have Neurontin. Generic of that is gabapentin, and it is an anticonvulsant, which is also used off-label for nerve pain, such as fibromyalgia and neuropathies. Next item down, we have Pamelor, and the generic of that is nortriptyline, and that is a tricyclic antidepressant. And the last item we have on this week's weekly quiz for the drugs is Prozac, or sometimes you'll see the brand name Seraphim. That goes by the generic name of fluoxetine. And this is a selective serotonin reuptake inhibitor, or SSRI. So those are how we enunciate those. I will post this recording online as well under your study guides and your practice test study guides and your study tools. So if you want to go back and re-listen to that, you can. How's everybody doing today? We can unmute. I'm through with my portion. We can chit chat for a minute.
I couldn't get in here at first. I was freaking out.
I did record it, so if you were having trouble and you need to go back, you might have missed something. I'm gonna post the recording under study tools.
Okay.
You can go back and rewatch and catch
I think I
anything.
got in here like right when you started talking. I was like, oh, thank God.
Well, hello, guys.
Hi, is everybody staying nice and warm?
Trying to still have ice on my car. I guess I'll turn my camera on. I look rough, but it's
Oh,
okay.
look, I see you.
Miss Jennifer, we not about to start this today, okay? Oh, yeah, I
I
think
do
it's funny.
apologize for the little bit of late start today. The surgeon came into my mom's hospital room like right at 10 o'clock
Uh-oh.
and started going over the procedure. So they're actually fixing her up today.
Wait, she didn't have.
Amen.
No, she was supposed to have it
No.
last Friday, and through some of the tests and things, they realized her situation was more complicated than they at first expected.
So if we have school tomorrow, we'll have a sub again.
Yes, ma'am.
Okay.
Well, I'm not coming.
Yes, you are. Yes, you are.
Mm,
She wasn't fast.
mm.
Have you gotten the
Um,
word that we are or not?
they have not said anything to me, but I think we're supposed to hit like 40 degrees today, so most things are supposed to thaw off. So I have a strong feeling that we'll be on for tomorrow.
Okay.
Well, our class is canceled for tomorrow. I'm signing off on it. Don't come tomorrow, y'all.
Have they dragged you to work, Alicia? You still there?
No, at home. No, at home.
It's the
Some
fact that I
people can.
came early.
Right?
Oh yeah, they wasn't playing.
We
Alicia, did
couldn't
you
be
see the
worse, Mildred.
TikTok I sent you?
Yes, I saw that.
Yeah.
Oh my gosh.
That was
I
funny.
wish I would. I'm
Not
politely
only
going
did
back
they,
in the
not
house.
only did they drag me to work, it was cold when I got there. It was cold all night.
Oh,
No
Y'all,
heat.
so tell me why we went and played in the snow yesterday, and my sister, she fell in slow motion. It was the funniest stuff ever.
my husband went and made a snowman with the neighbor kids.
That's funny.
He
Yeah, and
said
I
they had a
told,
snowball fight. I said, "How'd you make snowballs? It wasn't really sticking." He said, "We were spritzing it with some water so it would stick."
but it was so funny. It's like she just fell in slow motion, like in those movies. I don't know. And she just laid there, and I'm just like, Brayley, get up.
I just realized our recording's still going.